Ladies and gentlemen of the press, citizens of Kenya, this is a press statement following the full council meeting held at the Lake Naivasha Swela Lodge in Nakuru County today. The Council of Governors today convened an ordinary council meeting to conduct elections for the position of Council of Governors Vice Chairperson. The elections were conducted in accordance with Section 19.3 of the Intergovernmental Relations Act, Cap 265F. The governors unanimously elected His Excellency Muthomi Njuki, Governor of Tharaka Nithi County, as the Vice Chairperson of the Council of Governors. Following his election as the Vice Chair, the position of Whip fell vacant, and the governors subsequently elected His Excellency Benjamin Cheboi, Governor of Baringo County, to serve as the new Whip of the Council of Governors. In addition, the Council has commenced a two-day symposium to deliberate on and develop a unified county government's position on two major national programs. One, the Affordable Housing Program, AHP, and two, the Social Health Insurance Scheme, or SHA, if you like. These flagship initiatives have significant operational, legal, and fiscal implications on county governments, and the symposium aims to provide clarity, consensus, and strategic guidance on matters health. Number one, delays in claims payment by SHA. 14 months into SHA implementation, outstanding claims have reached over 10.5 billion shillings. These prolonged delays in claims payment or reimbursement negatively affects counties' creditworthiness and limits their ability to honor suppliers' payments on time. Therefore, SHA claims be paid or should be paid on a timely and predictable manner to avoid disruption of essential services. Two, on rejection of SHA claims. There is an increase in rejected claims, which currently stand at 10.4 billion shillings for public and private claims, with no appeal mechanism in place for claims when rejected by SHA. The Council therefore urges the Minister of Health to urgently develop an appeals or redress mechanism, including operationalizing the Dispute Resolution Tribunal, which is envisioned in the Social Health Insurance Act. This matter is very, very critical because it serves as a disincentive and a demotivator to the healthcare workers as well. When under FIF, they work and treat patients only to be told a huge percentage of the services they offered will not be compensated or indemnified in line with the SHA policies. then SHA ceases to be a fair insurer. 3, on the directive by the Medical Council on level 2 health facilities, level 2 and level 3 health facilities, which directive is affecting SHA claims. The directive by the Ministry of Health to stop maternal services with respect to deliveries at level 2 facilities has reversed the gains made in improved maternal and perinatal outcomes, especially in rural and ASAL, arid and semi-arid lands counties. The Ministry of Health should immediately, as agreed previously, because we had an agreement on this, should immediately rescind that directive to guarantee access to maternity services at level 2 and 3 as provided in the SHA maternity benefits package and pay for the services. Counties have an ambulatory service which is integrated with their hospital system. And this is why it's vital to allow deliveries at level 2 for normal deliveries. And as and when we suspect a delivery is assessed as a difficult or emergency, then the ambulatory system kicks in and delivers that mother to the nearest sub-county hospital. We have actually lost mothers in the process of trying to transfer them from a level 2, which has turned them down, to a level 4 when they could well have been helped at the level 2. And there were cases here of counties that have actually experienced a rise in maternal deaths as a result of this extremely impulsive decision that was taken by bureaucrats at the Ministry of Health, which was really uncalled for, if you ask me. 4th, access to SHA services by county staff. County government staff find themselves locked out of medical services, and this includes even healthcare workers, forced to pay for healthcare services out of pocket, even though the deduction on salaries would still be done upon payment. And this is because SHA has adopted a policy that if you don't pay premiums by the 9th of the month, you lose coverage for that entire month, regardless of whether you pay those premiums by the 10th of the month or the 11th of the month. The Council calls upon SHA to allow county employees to receive uninterrupted service, since remittance would still be made within the month in most cases, or within the fiscal year after disbursements by National Treasury. Why counties delay in meeting these deadlines of SHA is because of delayed disbursements by Treasury and the onerous process of release of money also from the controller of budget. In any case, SHA also takes months to reimburse us. So it's not fair to lock out employees when they themselves are not meeting their part of the bargain, which is to pay our reimbursements and our claims by the 14th of every month. Fifth, on the rollout of SHA ambulance services, Schedule 4 of the Constitution of Kenya designates ambulance services as a devolved function. Several counties, nearly all counties I would say, have existing ambulatory systems and structures that SHA can just decide to implement a parallel ambulance service open to everyone on a Uber-like scheme without as much as discussing with the Council of Governors, clearly steps on the mandate of county governments. SHA should therefore immediately engage the Council to review and harmonize the rollout of whatever ambulance system they have in mind. That the ambulance services should be expanded to also include inter-facility referral services. We had made this very clear that the ambulance system that they are thinking of rolling out for emergency services should be done in consultation with county governments so that we have a way of fitting existing county ambulatory services systems into whatever new arrangement. And this is why Article 6 of the Constitution constantly, we've raised this, has made it mandatory that the two levels of government engage on the basis of mutual cooperation and consultation. That's in as far as health and SHA is concerned. Moving on to affordable housing, the Council, together with the Ministry of Housing, State Department of Housing rather, and the Affordable Housing Board have discussed conclusively and agreed on matters relating to affordable housing program for onward submission of the same to the summit, which hopefully comes up in the next 2 weeks. This was a pre-summit meeting to iron out issues around affordable housing, from matters, provision of basic services in the housing estates, to processing of sectional titles for buyers of those units, and we have agreed on all the matters which the governors wanted discussed. The Council, therefore, is hopeful that the summit will adopt the outcome of the discussions that we've had today. Last but not least, the Council further held a consultative engagement with a mission for essential drugs and supplies, meds, and PATH, two key health sector partners of the Council of Governors. The discussions with meds and PATH centered on improving supply chain efficiency, strengthening service delivery, and expanding partnerships that enhance county health systems. Asanteni sana.
So what is going to happen if somebody is contented and there is a fire like that happened in the branch? And in that instance, the document that is approved in the document.
There was even the then Attorney General gave an advisory on how these things are actually going to be. And I think from
I saw them and get the material system. We check it. There is something even missing in the presentation. Of this funds for purposes of consent. So they cannot be international. Section 69, I say so because when I was in the Senate, the market was in the middle of town, and the building was going to occupy the entire space. So I refused, and I was asked this question even by the chief.
So that this affordable housing I think housing is good. People need housing. So some of the issues that I think here are very pertinent in making sure with the
Can Prof finish, please? Let Professor finish. Professor.
Sorry. Yes, sure. I think we went because in my county, for example, I just saw the things going on. And you couldn't oppose it because people want housing. For example, that now in Kisumu, affordable housing estates that are completed, an apartment block is cracking.
In the county government. So, Your Excellencies, those are the main issues that we flagged out as a committee. And
Chair, there was a communication that actually was done to myself.
So, Mr. Chairman, even without, I think the link and through the chair was presenting to say,
Should be good, but because we have not been in the driving seat, we may find in our hands a crisis that we never expected.
the intention of 69 was not affordable housing. 69 was projects like Flagada, projects like Konza. Those people.
Prime Cabinet Secretary, where he even wrote, and I think many are aware of this communication because we started this communication.
One of the issues that is actually being raised by governors is if something is rejected, right now there is no follow-up mechanism. That means there is no appeal. So we are now dependent solely on one person to make a decision, or maybe it's a team of people who make a decision. And if that is going to be the case, then at any given time, let's say collections are very, very low on a specific month, Exchequer has not come in for public health, or whatever reason that may be, if a rejection is going to be done across the board, then there's no way of us being able to appeal any of this.
And then the indiscriminate and unilateral closure of hospitals and downgrading of the same. Since SHA, the MOH at Afia has become too powerful. It's like they're running our hospitals from Afia House. Downgrading, regrading. There's even no consultation. How do you downgrade my hospitals without talking to me? Increasingly, we're seeing transfer of level 5s to level 6 in counties, which literally then means that counties have been asked to hand over their hospitals. It will be nice that we value these hospitals and they give us the money so that we can construct other hospitals. Because, see, under Article 209, ONSO's revenue comes from user levies and the services that you provide. So if your premier facility is taken from you, it also has consequences on ONSO's revenue. Of course, when you get a level 6, there's improvement of healthcare services in your county. But should there be discussions as to how this is done so that we're not just giving out our facilities? and this is the frustration that I have with SHA, that you agree on something and whatever you agree is not implemented. Months down the road, you are where you are, discussing the same thing again. From the onset, when everyone was calling it names and saying this thing is not workable, we stood firm, soaked in all the criticism, and said that this thing must be given a chance. But increasingly, we're also appreciating the serious challenges. The matter of not allowing level 2s and 3s to carry out deliveries, and maternal services, under the excuse that they don't have bed capacity. In most of the rural, and peripheral counties, we have a straight pyramid structure for our facilities such that a lot of them are actually level 2s and 3s. And if you don't allow normal deliveries to happen in those level 2s and 3s, you're actually asking mamas to be taken hundreds of kilometers to where there's a level 4, and in the process, you're actually losing lives. Elephant in the room when it comes to discussion of SHA is claims management and the whole reimbursement process, the rejection of claims, the late disbursements. The figures that the CEO shared with me, cumulative for all counties, is in the region of 32 billion shillings for public hospitals. And you see, it's very demotivating for our staff when they have actually provided the service and the claims they have logged in have been rejected over very flimsy reasons. When something is working seamlessly, you don't have to say that it's working seamlessly, because you'll be told by the beneficiaries, the users, the public, that it's actually working in a very seamless manner, without hitches. But definitely, SHA has challenges.
If the way SHA is behaving continues, a good example, in our level 2 and 3, from January to July, we conducted 1,000 deliveries, unclaimed. Now, what will happen if we turn back those mothers? Because SHA don't pay their reimbursement. 1,000 lives lost, or close to 20% of it lost. Because in northern Kenya, Chair, you come from that area. For example, in Mandera, we only have 7 level 4 hospital and 1 level 5. The rest, the 220-something health facilities, are level 3 and 2. If these issues are not going to be addressed in the next summit, I think then we should pull out of SHA. Thank you.
Good morning, Akina John.
Hey, morning.
You are good?
Very good.
Asante.
Whichever way, we must look for a position in the counties.
There's no choice.
There's no choice. Because we do the street lights, the bill will come to you.
For maintenance.
Yes.
This is my bill.
So now, Nengera mazina eva kugwanga. Neto. Neto. Remade.
Wale kwa dashboard. Upate ama meza hizi. Unafanya wiki moja
You know, we assume that we are very well catered for so long as we're in the tropics.
So what I suggest, Meds and Path, please give these excellencies your contact, and then during break, for those that have issues, since they're still here, can I then open it up for questions? Questions to Path and Med. Yes, Governor Sakaja.